That's not gonna be done. Good morning. Thank you, everybody, for coming out. I know that it's the first day of spring break. I don't think you have any spring breakers amongst the crowd, but okay. And I just want to remind everyone that the office is closed this week, but we're still continuing our collections, and there's still a lot of postcards. Whoever was here for the ACLU, and if you weren't, I have it recorded. We just got to get the vote out, and I know these postcards have a timestamp on them, so I don't have that many batches left, so that would be fantastic. Now I have to find. Oh, no. I have to.
Sorry.
I lost it. Okay,
Here.
wait, is this it? I can do it. I found
There
it.
you
I
go.
found
Okay,
it.
perfect.
First I go to Zoom, then I highlight me. So. So I want to introduce our speaker today. We have a small group, so I'm going to encourage questions. We also would love for you to sign the email list. And we also have an in-person survey. The young person who works with Scott at his office said, I'll send you a QR code. I said, yeah, no. So I didn't think that would work. So I want to introduce Scott M. Weissman, MS, CGC. You'll have to, we know what a Master's of Social Work is. You can tell us what a CGC
Sure, you got it.
in a hot minute. He received a Bachelor of Science degree in biology from the University of Illinois at Urbana-Champaign. And they went on in March Madness, so my house is very fixated on that. And I always look forward to the end of it. And after graduation, he spent 2 years working in a clinical genetic testing laboratory at the University of Illinois at Chicago, performing testing to monitor minimal residual disease in individuals affected by leukemia or lymphoma. He graduated from Northwestern University in Chicago with a Master's of Science, in genetic counseling. That's what the letters are.
You got it.
He has been board certified in general genetic counseling by the American Board of Genetic Counseling since 2002 and is a licensed genetic counselor in the state of Illinois. He is fantastic. He spoke here before at Macomb Solo Lakeside, and we're really glad to welcome him this morning.
Appreciate the invite to come back. Thank you. This thing is working. Yes, I'll just go louder. All right. Well, thank you for inviting me to speak with you all today. Again, my name is Scott Weissman. I am a certified genetic counselor. That's the CGC. And my training is in genetics, genomics, and psychology. So I know enough just to make my family a little bit nervous when I start talking to them about different things. So I'm here today to talk to you a little bit about hereditary cancer in the setting of what it means for the Jewish population, how it can impact your family, and then talk to you a little bit about our Sarnoff Center's hereditary cancer program that we just launched. Some of you may be aware that for, almost 20 years now, we've been offering genetic testing for family planning services for things like Tay-Sachs and Gaucher and Canavan that are more common in the Jewish population. Well, in December, we launched this program for hereditary cancer testing. We've been out in the community talking about hereditary cancer for years and years, but we finally felt it was time to start offering testing. And we're going to talk a little bit about today about why that is and why it's important. So, in terms of genetics and Jewishness and hereditary cancer, most people who get cancer, they really get it by chance. For a normal cell in your body to become a cancer cell, it has to go through a series of genetic changes that morphs it from normal to cancer. However, about 10% of the population who get cancer, they actually get it because they're born with one single gene in their body that is not working correctly. And that one non-working gene can then cause a much higher chance of getting specific cancers. It can cause people to get multiple cancers. And these genes can cause people to get cancer at earlier ages when most people aren't screening. I heard you all talking this morning about, what age do you start prostate cancer screening at, which is typically 50. But if somebody has a hereditary risk of getting prostate cancer, you're going to want to start screening at 40. So information like that can really help people plan what they need to be doing at a younger age so that if they are at a higher risk of developing cancer, they can be screening. So if they develop it, they catch it early. That's the whole goal of kind of all of this. And in the Jewish community, in our genes, there are certain hereditary cancers that are more common in the Jewish population. The same reason that Tay-Sachs and Gaucher and Canavan are more common in the Jewish population. It's the same reason that hereditary cancer is that when we're a population of people that are either isolated or tend to reproduce with other people who are also of Jewish descent, if there are bad genes in the population, they can flourish and grow if you're not mixing in kind of outsiders into the gene pool.
That's why we all wear glasses.
Yeah, well, this is when I've been doing this for years. In the genetic counseling session is the only time I hear Jewish mothers say, "Oh, he should have married the shiksa." It's the only time that I ever hear people say that, right?
No, what we say is, you don't say that, Scott.
Okay.
We say, we need to widen the gene pool.
There you go.
And that's what we need.
There you go.
We need to widen the gene pool.
There you go. But seriously, because we do typically tend to procreate with other people of Jewish descent, these genes can grow and flourish. And so that's why they are more common amongst our gene pool. So who in the room has heard about the BRCA genes? So almost everybody, for those of you at home. And those genes are kind of the stars. Like, those are the ones that make the most media attention. They tend to cause breast and ovarian cancer in women. They can increase the risk of prostate cancer in men. They can cause pancreatic cancer. They can cause melanoma. So they really can cause a broad spectrum. And some of you have probably already heard this stat before, but in the general population, you need to test about 400 people before you find one person that may have a mutation causing one of those two genes not to work. If you're going to do the same thing, but just test people who are Ashkenazi Jewish, you need to test 40. So it's 10 times more common in the Jewish population, the Ashkenazi Jewish population. And if you happen to have some Sephardi background, it's about 1 in 140. So it's still even more common if you are of Sephardi descent. Mizrahi, not so much. So because it is those genes are more common, it has become the standard of care to offer people testing for this. And for years and years, it was really, if there's a family history of breast cancer, if there's ovarian, if there's one of those cancers that I mentioned. But now we've gotten to the point that because those genes are more common, and we know about other conditions that are also more common in the Jewish population, the guidelines that we use to really offer testing to people have basically said, if somebody's of Jewish descent, they should consider testing, regardless of any family history of cancer. These genes can come from each parent. So if there's a gene that's causing breast and ovarian cancer coming from dad, and it came from his dad and his dad, it can be silently passed in families for generations because BRCA1 and 2 typically cause breast and ovarian. So there may not be any family history, and studies have shown that for Jewish families in particular, if you identify that there is a hereditary cancer risk, 50% of the time, there is no family history of cancer in that family. So this is why we've really gone to start kind of screening everybody of Jewish descent. As I mentioned, there are other conditions that are more commonly seen. Has anybody in here heard of Lynch syndrome before? Okay, so one hand up, most people, for those of you at home, not being aware of Lynch syndrome. So Lynch syndrome is actually the most common hereditary cancer condition. It's known for primarily increasing the risk of colon cancer and uterine cancer in females. In addition, with Lynch syndrome, you can see, unfortunately, a little bit of a laundry list of cancers. You can see ovarian. You can see other gastrointestinal cancers, things like stomach, small bowel, pancreas. You can see urinary cancer, so the bladder, the kidney, the tube that connects the two, the ureter. You can see brain tumors. You can see these rare oil gland skin cancers that are called sebaceous tumors. So big laundry list. So the numbers are you need to test about 1 in 280 people before you find one person that has Lynch syndrome. And it's not that much more common in the Jewish population, but it's about 1 in 100. So it's about 1%. It's still double the general population risk. So that's the second one that many people have not heard about. Third one that people also tend to have not heard about is something called the APC gene. And the APC gene is something that causes a condition that is known as familial adenomatous polyposis, which is big fancy medical words for saying people get lots of precancerous polyps in the colon. When I say lots, I mean hundreds to thousands, right? So most people that have this condition will go on to develop colon cancer. There's a particular genetic change in this APC gene that is found in about 6% of the Jewish population. It doesn't cause people to get hundreds of thousands of polyps, thank God, but it does cause about a twofold risk of developing colon cancer. So for people that have this particular risk factor, we know that they need to be having colonoscopies every 5 years instead of every 10 years if they have clean colonoscopies. And then the fourth one that's more common in the Jewish population, it's pretty rare, but it actually was discovered in the Jewish population as another condition that can cause people to develop lots of colon polyps and colon cancer. It's called hereditary mixed polyposis syndrome. And just like it sounds, people get lots of different subtypes of polyps in the colon. So there's a study that came out about 7 or 8 years ago that basically said if you screen people of Jewish descent for these 4 conditions and other ones as well, about 12 to 20% of people will test positive. So all of these things are actionable. It's practical information that you can use to work with your doctors to come up with a specific screening program to, again, if something develops, the whole goal is to catch it early. So I've been talking for a little bit now. I'm going to take a beat. I'm going to turn it over to Vanessa, and she's going to talk a little bit about her story.
I think a lot of you have heard my story, and I will condense it down and give you the salient points. I was diagnosed with ovarian cancer in November of 2018. And I will tell you, I can go through some. I immediately asked for a test for BRCA, and my insurance immediately turned me down. And I said, I'm Jewish, Ashkenazi. What are you talking about? So thank you.
Mhm.
My doctor had a call, my surgeon and my gynecological oncologist, and I was mad. He had to take time from his day to call the insurance and say she needs this. We would have paid for it. My insurance doesn't need to know that, but I think that in general, insurance just says no, and they wait for you to and then they give in. So that is one thing. And when I was talking to my doctor, he said, my surgeon, my oncologist, he said, I hope you have BRCA. I said, why? I said, I have a daughter. He said, there's more ways to treat you. And I think we know people living with cancer. I am NED, no evidence of disease. So I'm healthy. And it's been a long time. And I went through chemo and I lost my hair. And first I had a cold cap because Ethan, my youngest son, was graduating. And then after he graduated and we took the pictures, I said, I'm done. And I went back and they said, no, you have to continue. I said, no, I do not have to continue. And so it was a long process. And I know that my sister is online today. She was super helpful. And I will just share this one anecdote with you. I had a full hysterectomy and I came home the day of the Super Bowl. And who was playing in the Super Bowl that day but the Patriots? And my husband is a rabid Patriots fan. I said, "Are you sure I can't stay one more day in the hospital?" And they won, thank God. But I came home to that raucousness and my husband. So and Wendy was there and she really helped me. I mean, it takes a lot out of you, cancer and all of that. And I skipped over the first part, but when I went in, I wasn't feeling well. I went into the emergency room. I saw a young Jewish guy, and he knew immediately. And he kept saying, "Let's do a CT scan." I said, "Oh," he wanted to do a vaginal ultrasound. I said, "Why do I need that?" He goes, "If you don't want to do it." I said, "Nope, I'm here. If you think because he was looking for it. And my cancer was on the omentum, which is a lacy curtain that keeps your organs in place. But he knew. And he said to me, "You have to go see your internist as soon as you can." I said, "I will." He goes, "No, you have to go tomorrow." I said, "I will." And, she said, "You have to get the biopsy, blah, 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 blah." So I have a blog. It's called In One Ehrlich, and it's at every single person here has gotten the blog because I email everybody here, and it's in my signature. In One Ehrlich, that's my blog. And I also have a vlog for my grandkids, but that's a video log. But this, I wrote about my cancer journey, and I hope it's helpful for other people. The other thing, and as a Jewish educator, I just can't help myself. When I was finished, there's a prayer that you say when you escape danger. And it's benching Gomel. And I came one night and Rabbi called me up and I benched Gomel because I had escaped danger. The other thing that I did, I had always wanted to go to the mikvah, and I decided to go to the mikvah. And the mikvah we use is next to Beth Shalom because I think I could have gone to an Orthodox one, but they let me in. Beth Shalom is the preferred mikvah. And it was cleansing, and it was a great experience for me. And I'm very, very active in Shosheret. And the person at the Sarnoff Center now, Eve Kleinman, used to be at Shosheret. Shosheret means chain. And they help women with breast and ovarian cancer. And their gala was just this week. And they let I was honored a couple years ago, and it was a lovely evening. And then they like when I speak because I like to speak. So they gave me a throwaway thing on Wednesday night, but it's an important organization to me, and I have worked with it, and it helps women all over. And I had two other anecdotes. One, I had a friend of mine who was recently diagnosed with ovarian cancer, Jewish. She had never heard of BRCA. I said, "Well, what do you mean?" And I get it that some people haven't, but as Jewish Ashkenazi women, we need to be tested for that. And I think she was also BRCA negative. Now, with these genes, I have another friend, unfortunately, who passed away from breast cancer. She has two youngish daughters. They're in their 30s. They started their mammograms early, and one was just diagnosed with breast cancer. So I think these screenings. Get your mammogram. There's no screening for ovarian cancer. The blood that it's on, they check my CA 125. And if you have a high elevated CA 125, that's an indication of ovarian cancer. So, and there was no breast cancer in my family. After I had been diagnosed, my father died of pancreatic cancer. And I don't, I think there's some link there. Maybe Scott can tell us in a hot minute what exactly that means. And of course, The other Jewish curse in my family, and don't tell my boys I told you this, but they all have Crohn's. So, these are things why we need to widen the gene pool because it's predominantly in Ashkenazi Jews. Scott.
Yeah. So first of all, thank you for sharing your story. I mean, there definitely is a connection between ovarian and pancreatic cancer beyond the BRCA1 and 2 genes. You can see that in Lynch syndrome. There's a gene that interacts with BRCA2 that's called PALB2, and that mimics the BRCA1 and 2 genes. There are other genes called the RAD51C and D genes that can cause ovarian cancer that haven't necessarily been linked to pancreatic cancer. But I think the take home point of that is for people that actually had genetic testing however many years ago, there are opportunities to be retested. The technology is changing. The number of genes that we can test is always changing. So I do think if somebody in your family, had genetic testing in the past and said, oh, it was negative, it was BRCA negative, we really are encouraging people to be retested at this point in time.
So how, if I had my test 7 years ago, when do you suggest, should I get retested? And my sister, who's here, said, even though I don't have BRCA, should she still get tested?
So two good questions. So in terms of like how often to be retested, I typically tell people to check in like every 5 years.
Oh.
The reason being is that's where we typically see a lot of changes. So I would say probably the big change between the time that you were last tested and now is that a couple of the laboratories, not only do they test the DNA, but they also test the RNA now. And so what happens is when your gene is actually made up of pieces of important DNA, followed by pieces of DNA that generally don't do anything, followed by, again, important pieces. So it's like good DNA, bad DNA, good DNA, bad DNA. And so when the gene is used in the body to make a protein, the body has a way of cutting out all of the bad or junk DNA, putting all the good DNA together so that it can make RNA, which then is converted into a protein that your body actually can use. So when they do the DNA testing of the genes, they really only look at the good part of the DNA. What we've come to learn is that people can actually have genetic changes in the junk or the bad part that don't do anything that can still impact the gene function. And now the RNA testing can tell the laboratory to go back and look at those areas and can identify mutations that historically they would have missed. So that would be an example of like when to consider retesting. And for your sister, sometimes in families, there can be a hereditary risk, but people can still get cancer unrelated to the hereditary risk. So if we take away kind of your ovarian cancer and the fact that you tested negative, your sister still has a father that had pancreatic cancer. And so that's a situation where we would still recommend testing for your sister in the event that maybe your ovarian cancer just happened by chance, but your dad's pancreatic cancer was hereditary, and maybe he didn't pass it to you, but he passed it to your sister.
Yeah.
So depending upon what is going on in the family, there are times where we do recommend testing an unaffected family member, even if an affected family member has had a negative test. Does that make sense?
Yes.
All right. People are nodding their heads. Good. Okay. All right.
So when do you have to go get a test?
So we will, and we can talk about ways to do that. There truly are a lot of different ways that people can get genetic testing these days. You can go and you can talk to your primary care physician. Most primary care physicians are probably going to refer you to a specialist. They'll refer you to a genetic counselor like myself. If you are female and are still working with your OBGYN, sometimes the OBGYNs will do testing in their office. Some gastroenterologists are willing to do testing, but it generally falls into the bailiwick of the genetics professionals, the genetic counselors, the medical geneticists, especially in the city of Chicago. But like I said, in December, the Sarnoff Center launched a hereditary cancer program. So what we do is we have a online education module that people can sign up for. You get educated about what we're talking about today. And then people then get routed from the Sarnoff Center to me separate from the Sarnoff Center. And at that point, what I do is I will order the genetic test, and then we would have you get a saliva kit sent to your home. You spit in the tube, you send it back. It takes about 3 weeks to get the results back. And then we have a follow-up consultation with everybody to go over the test results. In the process, we ask you to give us your family history, who's had cancer, who hasn't had cancer, so that when the results come back in, positive or negative, we can make recommendations in terms of what you need to be doing depending upon what is going on in your family. The program costs $100. We waive that fee if there's any financial concerns whatsoever. The genetic test, we check your insurance benefits. If your insurance does not cover it in full, I will reach out to you. I will tell you how much the test is going to cost, and you can say, great, bill it to my insurance, or nope, that's too much. And the Sarnoff Center will offer financial support and will cover the cost of the testing. So we really don't want finances to be a barrier for people to getting this test. We want people who want to get it to have access to it. The test that we do covers 63 genes. So it covers in total about 11 cancers. What it doesn't cover are leukemias, lymphomas, what are called the hematologic cancers. There's different genes in the body that cause what we call solid tumors versus those that cause blood and lymph system cancers. So if you happen to have a strong family history of leukemias and lymphomas, you could still get this test, but I may actually tell you, hey, we need to do a different test, at which point the Sarnoff Center would be involved in taking care of that for you as well. Those hereditary leukemia and lymphoma syndromes are pretty rare. They're not more common in the Jewish population, but if you happen to have a family that warrants it, we will make sure that you have access to it. And again, it can help determine a screening program for you. As Vanessa was saying, if you've had cancer or you have an active cancer, sometimes knowing this information can influence the therapies that they recommend. There are certain chemotherapies that are more effective when somebody has a hereditary cancer. There are certain therapies that are called PARP inhibitors, PARP, that are used specifically for people that have hereditary forms of cancer that aren't necessarily always available for people who just get cancer by chance. And then for people in the room that have kids that are of the age of family planning, this information can be used for family planning purposes as well. Some of the hereditary cancer genes, so they're dominant. They're dominant genes. If you have 2 copies of every gene, you only need 1 copy not working to have the hereditary risk of cancer. Some of these genes, like BRCA2, if 2 people come together and they both have BRCA2 mutations, and they both pass along their BRCA2 mutations to their child, it actually can present as a different recessive condition that can cause, bless you, that can cause birth defects, that can cause childhood cancers, and a totally different presentation. So this information can be used for family planning as well, or for families that have unfortunately been really impacted by cancer and there's something hereditary. There's assisted reproductive technologies that people could take advantage of where if they didn't want to pass on a hereditary cancer risk to their children, there's ways to test embryos to essentially only implant embryos that are not going to have the hereditary cancer risk. Is there a question?
Yeah.
Oh, mind blowing. Yeah. It's something that's called pre-implantation genetic testing. We do it for the recessive conditions, again, Tay-Sachs, Canavan, Gaucher, et cetera. But we can also do it for the hereditary cancer syndromes as well. So we're really offering our program to anybody who's 18 or older. Most of these genes don't cause childhood cancers. But again, if there's a recessive risk of these genes, that's when you can see a childhood cancer risk. So if it's something that you were interested in doing, our website is jewishgenetics.org. There's a big button that says get screened, and then you can go and sign up.
And you can read Scott's full biography there. That was just part of it, what I read. I have a couple questions for you.
Sure.
My father contracted prostate cancer in his late 70s, and he lived to the age of 86 or 88, 86. The prostate cancer, nor did cancer cause his death. Should I get tested?
So typically, for individuals with a father or a brother or a son with prostate cancer, if it was the general population, just having prostate cancer and one diagnosis and not passing from it would not be enough. But again, because of the Jewish ancestry, you find these genes more commonly causing prostate cancer in men. So having a father with prostate cancer, even though he didn't pass from it, that would be enough to consider the testing. Where it's the genetic testing has become standard of care for certain situations. So any woman with ovarian cancer should get genetic testing, or her immediate family members. Any woman that has breast cancer under the age of 50, or a triple negative breast cancer, genetic testing regardless of any family history. Anybody that has pancreatic cancer should get it, or anybody with metastatic prostate cancer. Those are that's all you need. You don't need anything else. So if you have a family member that had one of those things, then you would also qualify for the genetic testing.
Is non-Hodgkin's lymphoma higher in Ashkenazi Jews? And if it's in your family, can you test for that?
So to the best of my knowledge, non-Hodgkin's lymphoma is not more common in the Jewish population. That is a cancer that the vast majority of the time, it tends to be by chance or sporadic. If there are multiple other people in the family that have had non-Hodgkin's lymphoma or leukemias, or again, if there's a strong family history of cancer, that's a situation where you could potentially consider testing. Most of these genes have a spectrum of cancers that they cause, but if we look at research, these genes can also occasionally cause one-off cancers. But so, there are studies that say that, maybe the BRCA1 and 2 genes cause a slightly higher risk of leukemias and lymphomas, but not enough that really warrant screening for them.
Also, for some of the people here, do you find that Medicare covers these tests?
Medicare will cover genetic testing in full for anybody that has had cancer. Okay. For people that have not had cancer, Medicare will not cover it.
Ooh, okay.
But this is where the Sarnoff Center comes in. If Medicare is not going to cover it for you, we will. And so we know going in, if you register with Medicare and don't have cancer, we just switch it to we're going to take care of it.
Okay, we have more questions. I have Blair, Jeff, and Marty. Blair.
I took advantage of Scott's services. Earlier here, and because I had some questions that were not cancer related, and I found it to be a very easy, very affordable process. Which I'm very grateful. Can you talk about some of the other areas where genetic counseling can help?
Yeah, thank you, Blair. So aside from what we've talked about in terms of, just to repeat the question for people online, just in case, the question is, where else can you do genetic counseling or genetic testing for, and why? So genetics is working its way into just about every aspect of healthcare. So if you have a family history of arrhythmia at young ages, or enlarged hearts, or sudden cardiac death, there are many hereditary causes that can cause those conditions. People that have sky-high levels of cholesterol, like 300, 400, 500, that can be hereditary. People that have aortic aneurysms or dissections, if that runs in the family, that's a situation. So there's cardiac, there's family planning, there's cancer, there's neurological. Certain families that have Parkinson's running through it, or early onset Alzheimer's, like onset in the 40s and 50s, that can be hereditary. There's certain kidney diseases. So really, if there's something that runs in your family that multiple people have had and they've had it early, sometimes there can be a genetic explanation. The one exception to that is, well, not the one exception, but there are some exceptions. Like we get a lot of questions about autoimmune diseases. You know, I have Sjogren's, you know, my mom had lupus, somebody's got fibromyalgia. So autoimmune conditions, not typically single gene type of conditions. You mentioned Crohn's. There are Crohn's, ulcerative colitis, um, IBS, all a little bit more common in the Jewish population, but not necessarily like single gene. It's more kind of multiple genes or genetic risk factors that are more common. And then you need other risk factors to kind of interact with the genetic risk factors to actually develop the conditions. And so, again, if you have something genetic that you think could be in the family, you can always reach out and the Sarnoff Center, you can reach out to the Sarnoff Center first, and I can talk to you a little bit more about it and then tell you whether or not there's something we can actually do in those situations.
Yeah, I have a question about, like 23andMe, for example, right, higher cost of offering these hyper level genetic testing. Are those as effective as what you would get from a hospital or your doctor or your center, or are they more probably?
Yeah. So the question for the people online is, what about 23andMe and the genetic testing that you can order online? Is it as good? Is it problematic? So,
We already know what your answer is.
well, it depends what you are looking for. So I will say that 23andMe does the 3 founder mutations in the BRCA1 and 2 genes. They have that on their panel, and they expanded it a couple of years ago to include 41 other mutations. It is not full gene sequencing, and it is not looking at all cancer genes. 23andMe, I would say, I would go into it looking at as entertainment. If you want to know more about your ancestry, if you like cilantro and eating it hasn't told you whether or not you like it, that test will tell you what kind of earwax you may develop. Like it's kind of entertainment. If you have a genetic condition that you're concerned about, I would not use 23andMe. I would also not recommend things like sequencing.com or Nebula Genomics, anything that you can purchase online by yourself without a healthcare provider involved. What I find is that these tests tend to advertise as learn about your health, whole genome sequencing, it'll tell you everything. If you actually read the terms and conditions, it will tell a different story. It'll say this is not intended for medical use. And when they give you results back, it is a genetic data dump. It is not translatable to the average person. It is difficult to translate for somebody that has genetics experience. So when people send me their results, it takes me a while to go through them and understand what they're trying to tell people. And what I've often found is that when people come to me to go over those test results, what I always do is recommend a confirmatory test. 0 times has the confirmatory test identified what the paid genetic test said that they have. We know it's a problem. There's studies that have looked at this, and about 50% of the time you get a false positive result on those tests because it's not high quality genetic testing, and there's nobody actually analyzing the data. They run it through online databases and AI and generate reports and just feed them to you. So I really tend, and they're several hundreds of dollars to do. So that's my unfiltered opinion on that. So.
So, thank you. This is really interesting. I was diagnosed with prostate cancer grade 2 at the right young age of 82. I have 5 grandsons and 1 granddaughter. I have no idea what my grandparents passed away from. My father passed away not from cancer, but he was only 69. What should I be telling my grandchildren? They're adult grandchildren.
Or your adult children.
Yeah. So the question is, I had prostate cancer at 82. It was grade 2, no real family history. You know, what do I tell my grandkids? So when we see prostate cancer at a later stage of life with no family history, more than likely it was probably sporadic. If I'm sure most men in the room have probably heard this statistic, but if every man were to live to the age of 90, 1 in 3 would get prostate cancer. It's just a organ that just tends to, become kaput as we get older. So more than likely, probably sporadic, wouldn't pose a huge risk to your grandkids if none of your sons were to get prostate cancer. Your sons would really need to start prostate cancer screening at 50. And I think it's important to reiterate that because several years ago, some guidelines came out that said we shouldn't be screening men for prostate cancer. And then there was a spike in metastatic prostate cancer diagnoses. And they said, oops, that wasn't the best recommendation. But not all doctors have gone back and have been recommending screening again. And then the last thing would be, I think, that's a situation where you would be a candidate for the genetic testing to see if it happens to be hereditary. Probably not, but it may be worth, if you're concerned about your sons, it may be worth talking to them, saying, hey, look, I'm thinking about doing this. Is this information that you want? Because I'd be mostly doing it for you guys. Have that discussion. And if it's like, yeah, I would want to know, then I think it's something that you could consider doing.
As a kind of follow-up for that, and in the world of ignorance is bliss. If you're someone who doesn't have cancer, but have family history of cancer, and you go through this testing and find out that you have these genes, what happens next?
So the question is, if you have a family history of cancer, right? And you haven't had cancer yourself, and you go through it and you find out you're positive, what's next? So the what's next would be, depending upon the gene, there would be a specific screening protocol that you would then follow. So let's say the BRCA genes. For men with no history of cancer, it's making sure that you're doing prostate cancer screening, which is a PSA blood test plus or minus a rectal exam where they're feeling the prostate. If there happens to be male breast cancer in the family, which can happen with these genes, sometimes we will talk to men about doing mammograms, but for the most part, it's making sure that you and your doctor are doing a good chest wall exam, because that's not typically done for a lot of men, just to screen for breast cancer. And then if it's the BRCA2 gene, it's recommended that everybody be screened for pancreatic cancer after the age of 50. Most people are not screening for pancreatic cancer because it is a little bit more invasive. It's doing what's called an endoscopic ultrasound, where it's like a colonoscopy, but they go down your mouth, you're sedated, and the scope has a special ultrasound tip at the end of it where they can image the pancreas that way. And then they recommend a special MRI. Those tests have been shown to be able to detect pancreatic cancer early and leading to better outcomes. For other genes, if there's a risk of colon cancer, it may be doing colonoscopies every 1 to 3 years instead of every 5 to 10 years. So it really tends to be gene specific, but it's to give people a plan. But it has to be right for you. So for people that maybe have concerns, they don't like living with the idea of, I'm under this microscope of screening all the time, it can be difficult information to learn and have. So I think the decision points for deciding whether or not this is something that's right for people are, do I want to know this information? Is this information that I'm ready to kind of act upon? And, do my kids maybe want to know this information as well, especially if I have adult children? Because if you're positive, everyone's going to tell you, you got to tell your kids. And so your kids can have these same discussions. The one thing I should mention with this is that, for people that do test positive, there are federal laws and there are state laws that basically say this type of genetic information cannot be a pre-existing condition when it comes to your health insurance. You can't lose your health insurance rates can't be raised. If you switch from Blue Cross to Aetna to Cigna, you can't be denied entrance into any of those plans. Federally, and in Illinois, right now there are no laws protecting life or other types of insurance. If you have it, you can't lose it because of this information. But if you don't have it, so typically people in their 20s and 30s may not have life insurance yet, or they get it through work and they don't, it's, your salary times 2 or something, and want to get more, that's a situation where I would typically encourage people to maybe think about getting an insurance policy first before taking a genetic test, just so that they are protected. And right now, there's an organization in Illinois called the Illinois Society of Genetics Professionals. They are working with state politicians to actually pass a law that offers protection for life insurance. There's a bill that's been introduced in both the House and the Senate. It was introduced last year. We knew it wasn't going to make it through. We think there's a good chance of it passing this year. So it's possible, maybe this year, maybe next year, there will be a state law that offers protection for life insurance moving forward. So definitely something to kind of keep an eye on.
Is the testing gender generational to the same gender, or do you, women, I have a son? Does the father then have to be tested for that son, or does it?
Yeah, so the question is the testing somewhat is it sex specific? Does it matter if it's your mom or your dad? No, it doesn't make a difference which parent, because it's they're genes that are located on chromosomes that men and women equally share. They're not related to the sex chromosomes, where women typically have two X chromosomes and men have an X and a Y. None of these genes are related to those chromosomes. So they can come from mom or dad just as equally. And again, in the Jewish population, there doesn't necessarily have to be a family history on either side. Does that answer your question? Okay.
It's been in the news more recently that it seems like there's a higher prevalence of colon cancer in younger people. And is there any thought of genetic underpinning to that, or they don't really know what the reason?
Yeah, so the question is about the increase in young colon and rectal cancers. So that is true. They are seeing there has been this trend over the past several years where people under the age of 40 are being diagnosed mostly with rectal cancer, more so than because they're actually colon and one tube, but considered two separate cancers are treated a little bit differently. They don't really know why that is. Thought is environment, diet, changes, things that we're exposed to, Instagram, TikTok, all those things. But it's gotten to the point that they did change the recommendations. So for years, it was baseline colonoscopy at 50. A couple of years ago, they pushed it back to baseline colonoscopy at 45 for everybody. You could do Cologuard, which is where the stool sample in the box, send it back. It's a good test. It detects a lot of things, but if they find something, you still need to have that colonoscopy. So I tell people it's just better to have the colonoscopy, have them really take a good look. Prep isn't as bad, right? Most of us in the room probably have had one. Prep isn't that big of a deal. But long-winded answer, but no, we don't know why it's happening. Yeah.
Sorry. Question. There in a between kidney, prostate, and pancreatic cancer.
The question is there a connection between kidney, prostate, and pancreatic? You can see all three of those cancers in Lynch syndrome. All three of those concur in that. Kidney cancer, there tend to be different genes that cause kidney cancer. And in the genes that cause kidney cancer, you can see a gastrointestinal tumor that are called GIST tumors, it's a cancer, but it's a different type of cancer. Or you can see head and neck tumors that are called paragangliomas, they're benign tumors, but they mess up your fight or flight response. So you can get like these adrenaline spikes. Outside of kidney and those tumors, I'm not aware of any other true connection between all three of them.
I had prostate and kidney, like both times they got it 0. His sister just died of pancreatic cancer.
Got it. So yeah, so when you think about risk factors that make people candidates for this, anybody that's had more than one primary cancer, that's a situation that we say, okay, that's a reason to consider testing. But there'd be enough going on there to say, yeah, that's a situation where you or your dad could consider testing. Yeah.
Her grandmother had breast cancer, her mother had breast cancer, and she had breast cancer. Mother had it at 60. I'm sorry, grandmother had it at 60, mother had it at 50, she had it at 40. They tested negative for BRCA gene. And when she was tested, this was probably 15 years ago, they said, you don't have this gene, you have a different gene. And I just, could you remind me, I think you sort of said that it might be kind of Lynch? Or they didn't test the BRCA right.
Yeah. So the question is, there's basically three generations of breast cancer that kind of got earlier in each generation, and they had a negative BRCA test. So 15 years ago, I'm trying to do math and it's early. That's 2011. So 2011, we were only testing for BRCA 1 and 2. The testing at that time still wasn't actually full analysis of the BRCA 1 and 2 genes. So if they were Jewish, it's possible they just tested them for the Jewish mutations, which again isn't full testing. So that's a situation where I would recommend retesting. Yeah, because it could be BRCA and it just wasn't, the technology wasn't there at the time, or it could be some other gene, like you said. Yeah.
I speak for Shasheret. I was at another synagogue. They had another speaker. She did not have breast cancer, the speaker, but she tested positive for BRCA. She had to have, mammogram after mammogram, and she decided to have a prophylactic double mastectomy. And I thought it was brave of her to share with the whole congregation and to let people know. And, she's very passionate about telling her story. She did a great job. And I think that, scan anxiety is a thing. And I get tested every 3 months for my CA-125. And, that day it's kind of like, but, and then my doctor has to get the results back to me, yada, yada, yada. I have another question here. So what age should an Ashkenazi Jewish person or woman get genetic testing? And does it depend on what's happening in their family?
Yeah. So what age is, it's really kind of a personal decision, because again, there has to be the understanding of, if I find this information out, I'm going to need to act on it. And some people are ready for that information. Excuse me. Some people aren't. Some people want to say, hey, look, I want to finish college. I want to start my life. And then I will think about dealing with this. Whereas if somebody comes from a family history where people have died from breast cancer at 30, they want to know sooner rather than later. So it really is a very tailored and personal decision about the right age. For what it's worth, for BRCA specifically, breast cancer screening starts at about 25.
Oof.
So that's kind of like, I would say, test when you can actually do something. Or if somebody plans on having children under the age of 25 and they want to know if they could potentially pass it on, they could test younger. But there really isn't a right or wrong answer. It's a very personal decision. And thank you for mentioning the woman that spoke at Shasheret. I haven't really talked about increased screening, but there are risk reducing options for some of these cancers as well. It's surgical options. There's mastectomy. There's removing the ovaries and fallopian tubes. There's removing the uterus. There's medications that can reduce the risk of breast cancer, ovarian cancer, and colon cancer. For men, we don't really talk about removing the prostate prophylactically. I have theories on why that is, which we're not going to go into today. But there are things that you could do to try to lower the risk from ever happening. But again, very personal decisions. There's no one size fits all, and really requires some careful discussion with the individual, their healthcare team, their family.
Well, a couple of questions. Number one, I'm a physician, but retired, and it was often very difficult for me to get patients to have colonoscopies, especially if they came from some before. So they Cologuard was good. They have an augmented Cologuard, and some of them don't even want they don't want to touch the poop. So now they have a Shield test that actually the colon cells. Colon cancer excrete DNA into their bloodstream, and they can and that's a kind of a new thing. And I wish they had something for like that pancreas, because it just seems so much pancreas problems. But the question I had was, if a woman does have BRCA and, one or two, and they're told they have their ovaries out. Should they do it people? Or should they put their eggs aside?
So that the question is, if a woman's going to consider removing her ovaries and fallopian tubes, should she consider putting her eggs, freezing her eggs ahead of time? The age that we typically talk to women about removing the ovaries and fallopian tubes tends to be, depending upon the gene, because there's variations. The earliest we typically talk about it is 35. So if a woman isn't done having her kids by 35 and she still wants to have a family and she really wants to remove the ovaries and tubes, then yes, absolutely. Create embryos, put them aside. Again, when you're doing this prophylactically for BRCA1 and 2, you don't need to remove the uterus. So, she could still carry her own pregnancy. So yes, that is something that we talk about in women that are in those situations. And then the other thing I want to comment on was, for those of you that didn't hear online, was kind of newer cancer screening tests. And I think a lot of them are early stage, but we're getting to the point of being able to screen for cancers just via blood-based testing. They're called either multi-cancer early detection tests, or some companies are doing single cancer tests, where through a blood test, they can screen for 50 different cancer types. One of the companies that does this is called Grail. They have a test called Gallery. There's another company called Caris, and I'm blanking on the name of their test, but there's Exact Sciences. They have Shield, and they also have one called Thrive. I think Shield's the colon one. Thrive is the full multi-cancer panel. These are really early tests. Most insurance companies aren't covering them. They're around $1,000 per test. And it's something that, for it to really have value, you need to do it every year, because it's looking to see whether or not you have an active cancer. It's not looking at to see if you have a predisposition to cancer. The issue with some of these tests is that what's called the positive predictive value is low. The positive predictive value is, if your test result comes back positive, what's the chance that you actually have cancer? So for the Grail tests, it's like 46%. So if you get a positive flag that says, hey, you may have an active cancer, 64% of the time it's going to be 54% of the time it's going to be a false positive result. So these tests aren't really at that level where we would say this is a great screening test, but I think they'll get there. I'm hoping in the next 5 years, because they're looking at like genes that are turned on and turned off. They're looking, as we get older, we have mutations just floating around in our bloodstream. Some of them they know can be precursors to cancer. So they're looking at genes being turned on and off. They're looking at mutations in your bloodstream to kind of generate this, do you maybe have an active cancer going on or not? So I think, coming back to your question a while ago in terms of what do you do with the information, I'm hoping that in 5 years, for people that have a hereditary risk, we're not only doing imaging, but we're also doing these blood tests and trying to screen for some of these other cancers early, and insurance will cover it, because that's going to be the key.
One more question.
Yep.
You have an elderly parent at age 95 that develops a colon cancer. How much risk is that for the children?
Not too much.
So
Not too much. I mean, technically speaking, that the children would still meet criteria to be screened every 5 years instead of every 10, but it's not going to pose too much of like a genetic risk.
Does most of your funding come from donations, or do you also get grants and other forms of funding?
Both. Funding comes from both grants and donors.
The Sarnoff Center is part of the Jewish United Fund. So they get funding there, and but that's where you work, right? Or do you work in two places?
So I work in my practice, and my practice supports the Sarnoff Center. So I work together with myself and the Sarnoff Center, basically. Yes. Yeah.
I'm putting the Sarnoff Center, their website, in the chat. I can send it to everybody here. And before you leave, we have a survey for you to take. And I can take a few last questions. I do want to say, though, that we, spring break, and then it's Pesach. But April 12th, we have a second generation Yom HaShoah Holocaust survivors, second generation program with Lev Learning, and it'll start at 9:45. And I'm announcing ahead of time, no breakfast. So don't be asking me on that morning, where's the lots of bagels? Where's the babka? Oh, now we've added babka. Do you have any, I'm sure that, Scott is going to stay. If you have any other questions online? Okay, come on. Oh,
Yes,
Jared.
I just want to say this was very informative and, you're very, very thorough, very knowledgeable. And I want to thank you.
Thank you. I appreciate that. Thank you.
All right, goodbye to everybody online.